74 studies. By checking the info, at the end of the day, we only got 8. And why do we have to review articles in order to have a very good application? It's because what we're trying to do is the best data that we can use for patients and the necessities that they have. So this is pretty much what it was important for us. The application that we will develop for these patients is based on this stuff here. Self-control of nutrition, the fluid intake, the medication, pretty much the health reminders that they have to do, and potassium and sodium intake, and educational material. These are the apps available in the world for patients, and as you see these, there are none for Mexico. So after checking this material, we have developed interventions, that is the second part of this job, related to this content right here. So this was the bias that we got like very good information that we found. Pretty much the general limitations that we have seen is that most of the stuff, it wasn't written in Spanish, and it wasn't like put it in context that is applied for Mexican population. Something that we wanted to do is something that is very easy for patients to use. So right now we're on the last stage of this application. This was the beginning of her dissertation project of my student. Right now we have the application after 3 years of working so hard with this app. It's been taking a long time, but you know, like having the skills for the IT, we have to hire someone to do it, and that's extra money and extra cost. So money obviously is always a limitation here and everyone around the world. So pretty much what she did is she used the scholarship that she was getting through the master's program to put it into the app. So we are working now with the patients in the last part of this. After this systematic review, we did the materials. That was another paper that we presented this morning, and pretty much the results that we're gonna get are gonna be presented in another project. But this project has been published in about 4 papers now, and we're very glad and happy to present some of this work. That is a very hard work that she has done and put through these so many years. And thanks for having me. Thank you.
Any questions?
What education level are you targeting the app? I'm from South Texas, so I see some similarities here with language and education level.
Right, yeah. Some of these patients, they don't know how to read and write, you know,
Exactly.
but they do have access to internet for, according like, their son or her daughter has a phone. So pretty much the interventions that we're doing, we make videos. So
That's what I was going to ask next.
yeah, we have the videos, and we validate the materials, like previous material. We did the video, we did the script, we got some experts and judges to validate the materials. We got validation. We have the videos, and the videos run in a Mexican context so they can understand what we're talking about. Because sometimes when you speak Spanish, it's different from every country, you know what I'm saying? And there are some videos out there in YouTube or anything, but these ones, what is an extra job that we put is that we got them validated. It's good info, it's information that's going to help them, and that's pretty much the job that is integrated. So we can talk later, maybe we can share the videos for your patients. Or the app.
And do you vary by age? The geriatrics seem to be very different than the younger groups.
Yeah, this was according 35 to 55. That's the media of age that we got, the target of people that we're working on.
Okay.
Because geriatric patients, they need other stuff, like they have a hard time like getting access to internet and information.
Right.
Yeah.
Any other questions?
If I'm allowed, I have a question.
Sure thing.
So I just wonder, often with apps, it's a key challenge to sustain them. So how do you,
Yeah.
because it's kind of
have paid now for using this, I think it's the cloud or something it's called, for 2 years, and we still trying to find a way. It's like the first experience of doing so, and it's the first app validated and done by nurses, because that's something that makes you really proud of it, because we are feeling and seeing the people. Some of my students had this dream that she said, I see these patients every day coming to the unit because she works there. So she said, I see them coming, they don't understand what we're talking about, no one is trying to explain what's this about, and we have a dream, and probably it's a very revolutionary dream for the time that we talk about digital and we talk about e-health and all of this, but for Mexico it's very different than for you guys. So it is a challenge. We haven't thought about the next steps, but I think what she said is what she's using is all her scholarship and her money, she's putting on that, and when you love something from your heart, sometimes you have to make big efforts, so that's what she's doing.
And I think sustainability is a challenge everywhere. It's a challenge here in the UK as well. To what extent can we actually, we pilot, we create all these beautiful apps and platforms, and then the question is how can we sustain them and grow them, and probably there's a lot more work we have to do in this space.
Yeah.
And apart from sustainability, and you've mentioned time, so it took you like 3 years almost. What were the other challenges that you?
Mostly, the beginning was that nobody believed in it. It was like, what you're talking about doesn't make any sense to me, because first of all, nursing informatics in Mexico is not a term that you hear like every day. Like our university, because I'm with the IMI and ESEP group, the emergency professionals, I have been working with them for more than 5 years. And thanks to them, I have learned so many things about it, and I have published stuff about it in Spanish and English so people can read it in my country. So that was a challenge, that they don't understand what is a nursing informatician, and they don't know what they do. Another one was money, for sure, and it's hard. Another one was the patient. Sometimes it was hard, as she said, to find this range of age exactly, like what to target to, because you have to really go through and learn from patients. And what we saw, like with geriatric patients, is that there is always one person in charge, like the caregiver. So sometimes she wanted to come and say, oh, I wanna use the app, but this is like not for you, it's for your mom or for your dad to use. So that's something that it was a little hard to understand, but after so much reading and research of these articles, we got the right for this. So yeah, that was a challenge, but as I said, we're dreamers, we have big dreams, and we have to think big in order to do big stuff. So that's why we're here, because we all have dreams.
Amazing, huge congratulations.
Thank you very much. Thank you.
That's how we make a difference.
And next we will get to give wonderful speech from the speaker, Yuan and 新书院。
You'll have to use the clicker. We are, sorry? So it's number 2?
2. Yuan, Yuan.
It's session 2. It's number 2, session 2.
Okay, okay.
Then what you have to do is just move the clicker.
Okay. This bottom next.
Yes.
Okay, okay. afternoon, ladies and gentlemen. Today I'm honored to be here to present our studies, the development and evaluation for the virtual reality nutrition device with vision, hearing, and smile. My name is Yuan Xinzhu. I cooperated with Lika. I come from West China Hospital Sichuan University and Nursing Sichuan University. Now it started with the background. Many preoperative patients experience various degrees of gastrointestinal symptoms such as nausea, vomiting during the postoperative period. These symptoms might prolong patients' hospital stays and increase medical experiences. Thus, maintaining of gastrointestinal function is the key to reduce post-operative complications, promote patients' recovery. Reviewing the previous study, there is various interventions addressing postoperative gastrointestinal dysfunction, including earlier oral feeding, earlier enteral nutrition, and probiotics. While some of them have limited effects. Then we introduce conception and shame feeding refers to the simulation of normal feeding process while including the enteral of food into the digestive tract for digestion or observation has been introduced as a measures for postoperative intestine function recovery in 2002. Shrinking as a form of shame feeding has demonstrated positive effect in promoting intestinal recovery and reducing gastrointestinal complications. The underlying mechanism might be associated with the limitation of food intake, stimulating the vagus nerves, then the regulating gastrointestinal hormones, or it could be related the interaction with the gut-brain axis. The conception of shame feeding is constantly updated with the innovation of intervention measures and be in-depth discussion of its mechanism. Lika defined the shame feeding as stimulating the state of oral feeding, stimulating brain nerves through the integrated audio-visual olfactory sense to relate psychological response and functional experiences. So we want to use this technology, virtual reality, to shame feeding somebody they can't eat food during the preoperative time. Virtual reality has emerged as a potential pharmacological intervention to promote recovery. VR combines computer technology and virtual reality equipment to provide immersive experiences. It has been applied in various clinical settings, such as alleviate anxiety and pain in surgical patients and help psychological rehabilitation for patients with mobility impairments. In the computer-generated immersive environment, users can move freely and interact with stimuli. In recent years, some researchers have applied VR technology in study of eating disorders and getting positive outcomes. Besides, VR enhanced conjunctive behavior therapy can reduce patients' appetite and improve their eating frequency. Up to date, there is a lack of reports on the development and application of VR feeding devices based on visual, auditory, and olfactory sense. Our primary object was to develop an immersive virtual reality artificial feeding devices that integrates audio, visual, and olfactory stimuli and test the device's usability. So we cooperated with machine and computer scientists according to the characteristics of clinical patients. And we printed 3D frameworks of order box and use the United 3D.5x to create our virtual reality screens. After the generation of equipment prototype, 17 patients were included for subject usability evaluation of the equipment. The system usability skills SUS was applied to evaluate the device's usability. It consists of 10 questions, includes both positive and negative framed items, each score on a 5-point scale. Meanwhile, the SUS has a high reliability coefficient. Now let's go to the result. We have developed a virtual fluorescent emission device by utilizing the mechanism of olfactory stimulation and the principles of condition reflect, and have constructed a virtual reality nutrition system. We collaborated with a scent development company and successfully developed 23 types of food order. By working with a computer software company, we successfully created 3 VR dining scenes. The nursing staff of our research team designed the appearance and function of the order boxes based on the characteristics of clinical patients. This is a device. We have a virtual reality and the whole look into the device like the right one. The VR handwear should include the peak head multi-display, peak controlled and olfactory order box, a wireless gateway, and the matching nursing chart, all of which are independently developed through hardware integration design and circuit optimization. The olfactory scent box has been developed to achieve when the users and patients take the handle to the food, they will catch the food into their mouth, and when the handle close to the VR, then the order box will let them smell the food. I have 3 videos to show you how the patients came into the virtual reality scenery, and they can catch the food they saw, and they can take the food with the handle. Then we can smell when they can smell the food. The device can perform various activities through 23 kinds of food order and comfortable dining environment in 3 VR dining scenery. By playing the detailed sounds of smelling, eating, drinking, and chewing, the real eating steps are stimulated for auditory simulation. And then we test the visual, hearing, and smelling by the patients, how they feel about this, and all the tests seems good. And the score of the SUS is 78.82, plus or minus 9.02. It means that the usability evaluation of this device is good, but there is still need to improve. Now let's go to the discussion. Currently, VR has been applied in medical treatment, nursing, education, rehabilitation, nursing, psychological nursing, and pain care. However, there have been no reports at home or abroad on the application of related normal psychological function and to improve the quality of life. The development of this device is expected to expand the application prospects of VR in clinical nursing intervention. Previous studies have developed virtual order generation devices, which are mostly large, extremely mounted equipment and are not integrated with VR technology, making it difficult for users to experience a truly immersive sensation. This device uses an olfactory sandbox and virtual dining software designed to complement each other, allowing users to smell the corresponding odor during an immersive virtual dining experience. This sandbox is portable and not restricted by the surrounding environment. The device models food and dining scenes is in a one-to-one relation, creating a realistic dining environment. It enables multi-angle views of the food and stimulates the dynamic presentation of food as it is picked up. The patient can pull the trigger to shift the dining scenes and press the call button in the scene to interact with the waiter. Clinical trials are ongoing. Want more data on scene and olfactory experience, authentic and clinical outcomes of the device has been collected and the feedback received. The prototype of the device can successfully present visual, auditory, and olfactory simulation through subject usability testing. The development of this device effectively expands the application prospect of VR in the medical field. The prototype of device has good test results. In the future, it will be applied to groups such as patients with surgery, eating disorders, obesity, and loss of appetite who cannot eat by their mouths. It is expected to promote the safe, comfortable, and rapid recovery of surgical patients, shorten hospitalization time, save medical costs, and provide new ideas for improving patients' experience. That's all. Thank you.
Thank you. Questions? We have 10 minutes for questions. Jane.
Thank you. Absolutely fascinating. And you've definitely demonstrated that this is possible. I think when we all go to restaurants, we choose food with our eyes, not just from the menu. I look over my shoulder and see what someone else is eating. And if I go shopping, the smell of fresh bread makes me buy it. So I think it's fantastic you brought it all together. I'm interested what you think about the patient's application in terms of if I'm trying to promote gut reflexes but I'm still nail by mouth, that might be quite hard for me to see and smell food if I'm not allowed to eat it post-surgery, even though I know it's promoting good gut reflexes. So I think maybe when you get to patients' user experiences, that might be more challenging, do you think?
Yeah, we have thought about this question. So we use this device for the patients they permanently cannot eat. For example, the patients who undergoing gastrointestinal surgery, they can't eat for 3 or 4 days, not for long. The reason why we want to develop this device is that when I was in the clinical situation, some patients told me that I can't eat, but I want to eat. When I see my family eat beside me, I'm so full. I'm so hungry. I want to eat. So we developed this device for them. But some people also ask me the question: if somebody they can't eat, but they can see and they can smile the delicious food, if they get disappointed, I think maybe somebody may be disappointed. Then they can't use this. And so before the patients use this device, they will be test if they can accept this device. This is it's up to the patient's thoughts. Thank you.
I think, Jane, my questions were around acceptability as well. So I think it would be great to see a bit more on that work coming through. We have another question.
Thank you very much. Yes, it's very fascinating to see the fusion of the different senses. So thank you very much for this excellent presentation. What I was just discussing with my colleague was whether you have thought about an application in eating disorders, such as anorectic patients who then get used to a more regular and normal way of thinking about food, eating, behavior, etc.
Sorry, can you explain it more deeply?
There are many, mostly it's young women and girls suffering from eating disorders, not eating, etc. And our thoughts were just whether you have thought about applying this technology for patients to get familiar with a normal eating behavior.
Yeah, we have thought about that, but the device now, it was used for the pre-operative patients, and maybe in next year we will use this device for the eating dysfunction people to simulate their eating habits. Maybe for the obesity people, for the someone have the eating psychological disorders. For further research. Thank you.
Thank you.
Thank you. So next is my pleasure to invite on stage Ursula Hubner, I'm saying this right, and she will present information in healthcare from data to knowledge, improving data literacy competencies. Very interesting. You have 15 minutes and 5 minutes question.
Yes. So I'm using this microphone. Does it work? Yes. So good afternoon, everybody. In the next 15 minutes, I would like to share with you our experience in further developing a course and implementing this course to improve data literacy skills. My name is Ursula Hübner. I jumped in for Nicole Eckbert, whose name appears as the first author, and I am the senior author, and I would like also to acknowledge my other co-authors, because we have a team of very international people. So we have Tina Hauka-Lilju, she's from Finland. Jens is also from Germany, as I am. Then there is Laura Phipps, and she's here with us in the audience from the United States, and also Mary Teets. She's also from the University of Texas at Arlington. And finally, we have Pedro Marques, he's from Portugal. So, data literacy, why is it important? So, it seems as if data literacy has become even more important than digital literacy, which has been intensively discussed in the past. And this is so because data are now the new gold of the 21st century. This is why data literacy is also among the so-called key competencies of the 21st century. Now, what is it? And there is one definition by Ridsdale, and he says it's the ability to collect, manage, evaluate, and apply data in a critical manner. And this is shown very nicely in the diagram, where data literacy is in the intersection of reading data, working with data, and communicating with data. So what did we do? As I said at the very beginning, we further developed a course which has been designed and implemented in a European project, the Erasmus project eHealth for All at EU. And you see the methodology which we applied, and I will go into the depths of it a little bit later to walk you through the different steps. And here you see the implementation of the course in the summer school 2 years ago at the University of Porto, with lecturers and the students standing below the famous Porto Bridge across the River Douro. So what is our methodology? We called it the pipeline of course development, and we started with a list of competencies, and this was derived from the Tiger Initiative. And then we further developed the specification of these competencies, because they were rather rough, defined as competency areas. We also validated them in focus interviews. Then we choose a pedagogical method, and we decided to use a problem-based, case-based learning scenario. Then, of course, we had to select an online learning platform. We ended up with Moodle, and then finally we developed the syllabus. So the didactic learning scenario of this course, and also of the other course I mainly focus on in my talk today, is a scenario that covers the so-called local learning health system. And we had an introductory scenario where we said a group of healthcare providers plans to improve the prevention of diabetes mellitus in the population of their patients. Data in EHRs of 2 hospitals and several physician offices are to be used to find the specific local determinants of developing diabetes mellitus. Based on these findings, a tailored concept for risk mitigation should be developed, and data analytics for a clinical decision support system should be designed. So this is what we gave the students. And of course, there are 3 questions that can be deduced from this text. They are, how can we access the data from the different systems, which leads us to the first component of the course, and that's all about interoperability. The second is, are we allowed to use these data, which leads us to the topic of data protection and security. And finally, how do we extract knowledge from the data, which is then covered by clinical data analytics. So these were the main course elements of the first development that was presented and implemented in the Porto Summer School. And in the further development, we thought, yes, these 3 components are still valid, and the evaluation of the students had shown that it was very interesting for them to hear about these 3 challenging topics. So how was our course implemented? It was implemented as an online, preliminary online phase and a face-to-face spring school at the campus of our university in Osnabrück, Germany. So, as I said, we had the 3 topics that already were implemented before. Interoperability, mainly FHIR. Data protection, mainly the EU General Data Protection Regulation. And data analytics, this was mainly pre-processing data and analyzing them through regression methods. But we now added 2 more topics. First, EHRs as a data source. So we had this topic to make it more realistic for students to learn about where the data come from. And besides the data protection issues that are more legal, the legal perspective of the problem, we added the ethical challenges when analyzing patient data. Now here you see a little bit information about our participants, 15 participants from different countries all over the world, from Germany of course, but also from Brazil, Ukraine, and the Netherlands and Austria, with a quite diverse background, professional background, so it was truly interprofessional. And this was a big challenge with different educational levels. So we had doctoral students as well as master's and bachelor students. So what are the results? And I do not want to go into all the details of these diagrams. So what you see here is just to give you an overview. We made an evaluation via a questionnaire, and this covers the topic interoperability. This covers the topic data protection, and this covers the topic data analysis. And we asked them whether they learned enough so that they got background information, that they understood the things, and that they were able to apply them. So it was not just learning in order to absorb information and knowledge, but also to apply this knowledge to data and to cases. And what you see here is the scale with a, is it blue or gray? Well, here it's blue, here it's more gray. So the light gray or blue reflects I agree strongly, and the darker blue or gray reflects I agree, and all the items are phrased positively. So yeah, we can see it's a positive picture that emerges from this survey. And as a summary, we can say the awareness of all the 5 topics, including ethics and EHRs, was raised. Their meaning for practice became clear, and the ability to apply analytical methods was strengthened. The new 2 topics rounded up the curriculum. Now, did the course meet the expectations of our participants? And what you see here again, it's a picture that reflects a very strong agreement here, and an agreement. There were some neutral responses, but none said disagree or strongly disagree. And what they learned was to improve an understanding of the 3 and 2 topics, so interoperability, data protection and analytics, plus EHRs and ethics. They got, this is what they said, they obtained a good theoretical background, and they could apply this background. Now, this is all about the knowledge and the application of the knowledge, but also what counts in summer schools and spring schools is how the people felt. And the participants reported that they very much enjoyed the international exchange, working in small groups together, and the case-based learning or problem-based learning that we applied. Now, it's always interesting to know what can be approved. They told us, and of course it was not a big surprise for us, it's the 3 and the 4 and 5 topics are very demanding. Yes, they are, and we knew this right from the beginning. However, we thought it was a good starter for the main course, and they, the participants agreed. They thought, yes, through this course, their awareness was raised and their interest was raised, and now they are ready to take a full-time course outside a summer or a spring school. So what is the takeaway message? So the first part is that our participants said they developed a deeper understanding of what it takes to extract knowledge from data. And this is really the basis for AI. This morning we had a very interesting panel on leadership in nursing informatics, and one of the ladies said, yes, it's all about data, and data that is then used to build AI systems and clinical decision support systems. So this is why it is important. But other competencies emerged from our approach besides data literacy, and that is critical thinking, problem solving, collaboration and communication, and also intercultural competencies. And this is so important for health professionals, as data are the new gold for transforming our health systems, to improve the quality and to ensure patient safety, and of course to conduct research at all levels, the local up to the international level. Now, broadening the scope a little bit and moving from data literacy competencies to a more broad view, that's nursing informatics competencies. And I would like to invite you to participate in a survey. Here you see the flyer, and my colleague Florian has a paper flyer which he can hand over to you, where you find a QR code which leads you to the questionnaire, where we would like you to invite to give your opinion on the priorities of core competency areas. And with this, I'm ready to take questions. Thank you for your attention. And I would like to tell you this is Nicole, who couldn't come today. Thank you very much.
Any questions? If not, I have a question. So what next?
Yeah, that's a good that's a good question. Well, there are things we can improve, and I didn't show it on the slide. It was a problem that appeared already at our first summer school, and it appeared in the spring school, and that is the connection of the 5 topics. So the people, they got an understanding what is fire, they knew what the EU data protection regulation is, they knew data analytics methodology, yes, and they knew, okay, this is ethical, this is non-ethical, and I get the data from the EHR. But it should be a more coherent story. So to show the flow of knowledge that is needed in order to arrive finally at a result from a regression analysis, and that shows you diabetes mellitus is developed in this population here and there in our area, and so on. So I think we have to invest more time to make this clear to the students. And yes, and again, of course, the topics are demanding, as our participants told us. Yes, so maybe we can, yes, we can improve this a little bit, maybe a little bit softer teaching methodology or whatever. So I think there is space to improve things. That's right.
Thank you. Jane.
It's just an observation, not a question, but you said it was challenging that they came from many different professional groups. I wonder if that actually added to the richness of conversations and interactions. Yeah.
I fully agree. Yes, it's not only a challenge, but it's also a benefit, because they told us that they then discussed the topics from various angles, and this was very enriching. And this is what they told us. It's the work in the small groups, the intercultural exchange, but they also meant the interprofessional exchange. And also the different levels of education. I mean, you would say, okay, why do you want to mix a bachelor student with a postdoc person? But in a group with a good mix, then people could help each other. And sometimes the bachelor students would help the others to find the function in the application, whereas the others would say, okay, you have to think about what diabetes is, etc., and what are the risk factors. So I think it's both ways. It's not just the postdocs telling the bachelors what is good and what is bad.
Fascinating. Thank you. Any more questions? No? Thank you so much.
Yes, thank you.
Last but not least,
Yeah, no further discussion. We welcome next speaker to present this data. The next speaker is Sijia Li. Yeah.
Okay, good afternoon, everyone. My name is Li Sijia. I'm a master student in Peking Union Medical College. My advisor is Professor Piaomei Hua. Today, I'd like to introduce my research, mobile application-based interventions for overweight and obese adults, a systematic review and meta-analysis of weight, behavioral, and metabolic outcomes in randomized controlled trial. I would introduce this research in the following 5 parts. Firstly, some background information. Overweight and obese are defined as excessive fat accumulation that can potentially have a negative effect on health. Overweight is classified as having a BMI of 25 to 29.9 kilogram per square meter. Obese is classified as having a BMI of 13 kilogram per square meter and over. And now, 43% of people are defined as overweight and 16% of them are obese. This population is related to many health consequences such as cancer, dementia, and respiratory diseases. So this population is very important for us. We need to intervene them in an early age to lower the incidence of disease. Now, the basic approaches to lose weight are multi-component behavioral interventions. With the advent of technology, we have a new way to lose weight. Mobile health applications are promising in health behavior change. Mobile health is defined as medical and public health practice supported by mobile devices such as mobile phones. It has many advantages such as wide reach, cost effectiveness, and improved feasibility. Because of these advantages, it has the power to help people lose weight. In our paper, we'd like to see the effectiveness of these devices. We know that there are some current reviews in this regard. However, some limitations exist in current reviews. First, limited outcome synthesis. Most reviews limited outcome measures to weight and BMI. However, other outcomes like WC, fat mass, and blood pressure, etc., they are very important and they have their clinical significance, but they are not reported in current reviews. Secondly, a lack of behavioral intervention components identification. We all know that behavior interventions are the cornerstone of weight loss. So we need to see these interventions from the perspective of behavior change. I have used the 2 tools in this process and I'd like to explain them to you one by one. Firstly, behavior change techniques. Behavior change techniques are the smallest replicable intervention elements designed to modify or redirect the causal mechanisms that regulate behavior. They are widely used to guide and understand behavioral intervention designs. Let's look at these 2 pictures in detail as the contents of BCTs. We can see that there are 16 categories, and in every category there are some specific items. Let's take one, for example, goals and planning, and there are some specific items like goal setting, problem solving, and action planning. I have also used another model that is called Behavior Change Resource Model. It is proposed in 2020. It's a new model that is centered on an individual's resources to elucidate resources used to form these BCTs. So BCTs and Behavior Change Resource Model, they are not distinct, they are related. In this model, the resources have divided into 3 types: facilitating, boosting, and nudging. When we are mentioning facilitating, it means a person uses external resources, such as social support. And boosting and nudging means a person uses internal resources. When we are mentioning boosting, it means a person uses reflective resource, like the person should use their cognition to do something, like self-monitoring of behavior. And nudging means a person uses affective resources. The person uses their affection to do something, like social influence. They are influenced by other things. So based on our background, we have 2 primary objectives of this research. First, it should provide a comprehensive outcomes exploration, including weight-related, behavioral, and metabolic outcomes. Next, we identify behavior change intervention components using BCTs and behavior change resources. I have registered this review on Prospera platform. We have searched for 6 databases for relevant RCTs published between 2010 to 2024 in English. This is a search strategy on PubMed. This is our study eligibility criteria. We have included adults with overweight and obese. The intervention includes mobile phone applications used as a major component. Eurocare without mobile phone application interventions or no intervention was comparisons. We have excluded participants diagnosed with other diseases except for obesity. This is a pre-designed Excel that is used for us to extract useful data. We have also conducted quality assessments. We have used the Cochrane Risk or Bias tool to assess the methodological quality of the included studies. This tool includes 7 items, and we have also conducted some statistical analysis, including meta-analysis, publication bias assessments. In all analyses, p less than 0.05 was considered statistically significant. Let's look at the results section. We have included 29 studies in this systematic review. These studies were conducted on Spain, France, UK, Korea, India, etc. The sample sizes ranged from 20 to 650, and the average age of participants ranged from 22 to 55 years old. The behavioral theories, including social cognitive theory, self-regulatory theory, were also included in the intervention design. The intervention duration ranged from 2 to 24 months. This is the risk or bias of included studies. Because of the nature of the intervention, it's impossible to blind participants and personnel. So in this item, we regard it as high risk or bias in all included studies. This is the forest plots of weight-related outcomes, behavioral and metabolic outcomes. I have a table that shows the meta-analysis results on each outcome. We can see that we have synthesized 3 categories of outcomes. The most important outcome is weight. We can see that mobile health applications reduced 1.45 kilograms with statistical significance. Other than that, other outcomes including BMI, WC, fat mass, DBP, and HbA1c were also reduced with statistical significance. And then this is identified behavior change techniques. We have mentioned it in the background section, and this is the frequency of them. We can see that of the included 29 studies, 25 studies have used self-monitoring of behavior, instruction on how to perform the behavior, feedback on behavior, goal setting, and social support were most widely used in included studies. So if we want to get behavior change resources, we need to map BCTs to behavior change resources. This is very subjective because there is no standard in this field, and this is the criteria in our systematic review. Let's take one example to explain this criteria. Like monitoring of behavior by others without feedback is categorized as nudging because it uses a person's affective resource. This is the identified behavior change resources of each study. We can see that most studies have used the 3 types of resources, and other studies used 2 types or 1 type. So let's look at the discussion section. What's the implications of these results? Firstly, we have included 29 RCTs in this systematic review, and 11 outcomes are explored. Mobile health applications reduced weight, BMI, WC, fat mass, DBP, and HbA1c with statistical significance. Some BCTs were identified. Self-monitoring of behavior and instruction on how to perform the behavior were most widely used in the included studies. Most studies utilized the 3 types of resources. And let's look at the interpretation of meta-analysis results. Most weight-related outcomes were reduced with statistical significance. However, no significant reduction was found in fat mass percentage. It may suggest that when we are losing weight, we may also lose lean muscle and bone mass. However, they are very important for our health. So maybe in the future, we need to focus on fat loss plans instead of just focusing on weight loss. And nextly, metabolic outcomes. Previous evidence has shown that 5% weight loss means clinical benefits. It means that if you are 16 kilograms, you need to lose 3 kilograms to gain clinical benefits. However, in our meta-analysis, we only found that mobile health applications reduced 1.45 kilograms, so it failed to reach clinical benefits. We recommend that maybe in the future, we need to optimize our intervention design to enhance the effect sizes to gain clinical benefits. So how to optimize our interventions? Let's look at our behavioral outcomes. And no significant reductions were found in MVPA and energy intake. MVP means physical activity, and so there might have some limitations exist in the behavioral design. Let's look at the BCT results. We have identified that self-monitoring and instruction are most frequently used. On one hand, they are well perceived and widely used among researchers. On the other hand, there is a potential risk of over-reliance on monitor and instruct when we are designing the interventions. So maybe other techniques that are more important, like habit formation, should be developed and explored in future studies. Next, behavior change resource model. Most studies have used 3 resources. However, we need to consider how to make full use of these resources to enhance the effect sizes. We recommend that when we are designing our interventions, we need to take participants' considerations into account. We may interview our patients or populations to optimize our intervention design. So there are some strengths of this systematic review. Firstly, it provides a comprehensive summary of outcomes. And next, it has identified behavior change techniques and resources used. It's the first review to link behavior change techniques and resources. So it might provide us some ideas to optimize our intervention design. There are also some limitations in this paper. Firstly, we only included overweight and obese adults without medical conditions. The results may not generalizable to other populations. Next, the coding process, behavior change techniques, and resources coding process involves subjectivity. Although it shows good reviewer consistency, this process needs to be standardized, and especially mapping BCTs to resources. Lastly, we did not conduct any subgroup analysis or meta regression to link BCTs or resources and outcome effectiveness. That might be the future direction. Thanks for your listening. That's all about my research, and this is my self-information. I come from Camp Sneer in Chinese Academy of Medical Sciences. If you have any question, you can contact me through my email. Thank you.
We have 5 minutes for questions. Any questions?
Yes, thank you very much for this very thoroughly done study. You mentioned that you used a Cochrane tool. Did you register this study as a Cochrane study?
I have registered it on the Prospero platform.
Yes,
Yes.
but it was not an official Cochrane study.
Not a Cochrane study.
Yes. Have you thought about doing this?
Okay, I know that the Cochrane registration takes a long time. Yes, the Prospero is much faster, so we choose to register it on Prospero. Yes. Okay. Ensures user engagement. Okay, that's also the meaning of this paper. We advocate that when we are designing interventions, we need to consider the participants' perspectives or ideas. Like, we have identified the resources used in these intervention designs. However, when we are designing our interventions, we just think, okay, we need to use these resources, but we did not consider whether the participants have this resource. Like, we want to design some social support elements, but the participants do not have the resource. They do not have some like friends or experts to support them. So that's the reason why we conduct this systematic review. We advocate that maybe in the future, we need to consider the participants' ideas or their situations to help design our interventions. So that is user-centered design, yes.
And I think co-design also works in this situation where you bring participants within the study to understand their perspective as well. I just wonder, based on you reviewing the papers, if the authors revealed any challenges associated with the interventions.
Challenges associated with interventions?
With the intervention, with the application they've developed.
Okay, sorry. Okay.
When you reviewed the papers at having... I'll speak to the mic, thank you.
Okay.
So you reviewed the study that you have included in the review, and I just wonder, when you've gone through the different papers, if the authors of the papers highlighted the challenges they've experienced.
Okay, the original studies included?
Yes.
Okay.
Only if that's something you've noticed in the review.
Okay, let me think about. I think the most challenges is effectiveness. Most studies have limited effectiveness, and there are many studies that is not statistically significant. Maybe there are some studies that is negative and they are not reported. So I think how to enhance the effectiveness would be the most concerns among researchers. Yes.
Okay, thank you.
Okay, thank you.
Any other questions? No? If not, this concludes our session. which really highlighted the level of innovation in nursing informatics, so from applications to VR to data, education as well. So can you please give another round of applause to all the speakers? Thank you. And enjoy an eye. More to come.